Hi, everyone. Welcome to the Spine Nevada virtual seminar on how to manage and treat common spine and joint injuries without surgery. This is Molly Canaday, Director of Integrated Marketing for Spine Nevada. We are excited to have all of you join us this evening and grateful to have this opportunity to share recent updates in spine and musculoskeletal healthcare. We'll have time at the end of Dr. McDermott's presentation, so please enter in your questions into the Q&A box at any time during the presentation. Without further delay, I'll turn the presentation over to Dr. Hugh McDermott. Welcome, Dr. McDermott, and thank you.
Hello, thank you, Molly. My name is Hugh McDermott. I'm one of the PM&R and pain physicians here at Spine Nevada, also focusing on musculoskeletal things, which is what we're going to talk about today, which would be some non-surgical treatments for musculoskeletal injuries. So thank you for joining us. The focus of today's talk is going to be an overview of what orthobiologics is, specifically as it pertains to PRP, which is platelet-rich plasma, bone marrow aspirate concentrate, also known as BMAC, and lipogems or fat aspirate. And we'll get started. Questions will be at the end, but feel free to share them throughout the lecture. So first, a little outline of who I am, what we do here at Spine Nevada, what is this orthopedic treatment gap, and what are we doing to try and close that? That would be orthobiologics, what those are exactly. Again, this is going to be a brief overview, so nothing terribly in-depth, but we'll get into some of the nitty-gritty. What is going on with these cell therapies? What is the wild, wild west? What's the FDA saying? And what are we doing here to comply with all of those mandates handed out from the FDA? Most recently was last year, and we'll get into that. And then the specifics a little more so about platelet-rich plasma, bone marrow aspirate, and lipogems, the procedures themselves, what we use them for. Okay, so here we go. So myself, I graduated from Notre Dame for undergrad. I'll cut my wife off here. And then I went to the University of Illinois, Chicago, in Chicago, excuse me, and graduated there in 2015. Met a friend there who said, "Hey, Dr. McDermott, do you know how someone went to Notre Dame?" And I thought there was something about us that, you know, made us unique. And he said, "They'll tell you." So did again. There you go. After medical school, I went to residency and then pain fellowship at Emory University down in Atlanta, which is over here, up on the rooftop here during the solar eclipse. We got to watch it from the helipad, so that was pretty cool. Then moved immediately out here with my family, right over here. Last fall, late summer, early fall, we've been enjoying all things Northern Nevada, Tahoe since. And this picture is taken from Chickadee Ridge, which is a great little hike for kids and everything. We had a lot of fun, and just thinking about all the people who have been going through the fires and smoke, and if your livelihood was kind of uprooted recently because of that, or you know someone that did, prayers out to you guys. All right, so down to the lecture here. What kinds of symptoms are you experiencing? People get painful joints, backs, necks, shoulders, etc. Is it worse when you're walking or running? A lot of times people have difficulty just getting up out of bed in the morning, getting down their stairs. Maybe getting out of bed is because you didn't sleep because you were having pain all night, or just moving around, or difficult time doing your work function. What can we do about it? Well, these orthopedic issues are pretty widespread, probably not unique to you. You probably have some friends or family that you talk about your knees together with. And just looking at it from a national perspective here, this data is as of 2017, that people came to see the doctor over 12.5 million times just for knee pain, 4 million times for hips. Shoulder was about 6.8 million. We'll talk about it in a sec here too. This leads over time every year to an annual hip and knee replacement of 650,000 to 400,000 for the knee and hip respectively. And these can be very successful. These can be life-changing for vast majority of people who get them. But we'll look later in a second here that about 1 in every 5 people who get a knee replacement say that they're unsatisfied with it or wish that they hadn't had it in the first place, which leaves a lot of patients out there that maybe could fill what this treatment gap is that we'll talk about in a second. Again, previous medical options for treating these painful joints and soft tissue issues, medications. We all know about opioid epidemic that we're continuing to go through, leading to tolerance, dependence, accidental or purposeful overdose, unfortunately. The surgeries, which again can be fantastic, can be life-changing, but do come with risks like all surgery, leading to complications, some long-term rehab. Some of the procedures that we offer, you go home the same day, obviously. You might be sore for a little bit, but you get back to what you were doing quicker. And then a run-of-the-mill steroid injection or cortisone therapy. Over time, if you get several of them or too many in a year or for years and years getting steroid injections, it can lead to bone demineralization or bone weakening, as well as weakening of the tendons themselves, putting them at risk for, if they were already torn, further tears, or if they hadn't been torn in the first place, increasing their weakness and putting them at risk for long-term injury. And then steroid injections do eventually wear off. Of course, there's the every once in a while patient who gets one, feels fantastic, gets back to doing the things they were doing, and we never see them again. And that's always the hope, that's always the goal. But more often than not, it's a short-term result and they're back within the next few months, within the next year for another one. So this is the treatment gap we were talking about, where someone starts to have pain in the joint. Let's say, again, the knee, just for example. And over the course of time, all the things that we did to try and help with that knee pain would be what that treatment gap is, meaning you start to accrue costs. So the visits to the physician, bracing, physical therapy, maybe you did medications, maybe you did these steroid injections or hyaluronic acid or the what's called colloquially like the turkey fat injection, the gobbler, can lead to a long, over time, cost, and eventually may undergo like a major surgery anyway at the end of it all. The reason for it, again, is multifactorial, and often it's people not wanting to have surgery, or you're too young in the first place. We probably shouldn't be replacing hips and knees before the age of 50 is usually what orthopedic surgeon's cutoff is, unless, of course, there's a traumatic reason for it. And so we're putting off trying to just get to the age of 50, perhaps. And that can lead, again, to increased costs, increased burden over time. And that's this treatment gap that we're trying to close for people. So what is orthobiologics, also known as interventional orthopedics? This is from the Interventional Orthopedics Foundation themselves, of which I am a member, happily. And it focuses on precise placement of orthobiologics under exacting image guidance, which could be X-ray or ultrasound. And then what's injected instead of your run-of-the-mill steroids and things like that would be these regenerative biologic treatments from adult cell therapy or platelet-rich plasma. And, you had to do a fair amount of training before kind of being qualified to do these out of your office. So we combine interventional spine, which again, I'm fellowship trained in non-operative orthopedics and sports medicine, which we do throughout residency and fellowship, kind of put them all together in a bucket and kind of come up with our interventional orthopedics here. So this is an example of what the fluoroscopy machine looks like. We also use ultrasound to help guide placement into the soft tissue, into the joints themselves, in and around nerves, you name it. We can usually find things with multiple different ways of locating them. The fluoroscopy machine is X-ray, so image comes up on the screen here. We're taking live images, so barely move a needle, take another X-ray to make sure we're going on the same trajectory. It also allows us to look at contrast. We always make sure we're not in any blood vessels. So the other nice thing about ultrasound is you can see all those things in live time as well, in and around your needle. So what do we do here at Spine Nevada? We focus on 3 primary orthobiologic treatments. Those would be platelet-rich plasma, bone marrow aspirate concentrate, and lipo aspirate, specifically Lipogems product. This can help again with the healing process and get you hopefully moving forward here. Okay, and now before we get too much further in, I wanted to briefly talk about what we do not offer here at Spine Nevada, and those would be the allograft products. So these would be, for example, like the amniotic stem cells, umbilical cord blood, it's not listed here, Wharton's jelly, or exosome treatments. And all 4 of these, bar 2 small companies, are at some point have been in violation of this FDA Rule 361. And that means that they have gone beyond the requirements for minimal manipulation or homologous use. And the lack of orthopedic evidence for them is another reason, of course, not to use it. And they've had extensive marketing campaigns, but their treatments have shown, no superiority to the treatments that we offer, such as PRP or stem cells, and actually cost much, much more money than PRP. And between the violations of that FDA 361, as well as the cost and non-proven orthopedic efficacy, bar those 2 companies, which again, those products are only approved for knees, and their cost is so much more than PRP that we don't use these. We've been approached to use them before, but we are steering clear of them for many good reasons at this time. Will it change in the future? We have no idea. But for the time being, if you were wondering if we use any of these products, which again, I didn't include Wharton's jelly here either, the answer is no, we do not. And this other important detail, one that I don't love talking about, but it's important nonetheless, because this can be a hindrance for some people, and that is insurance doesn't cover these things because they're still considered experimental, even though, as I'll show, there's getting to be more and more data. The stuff I'm going to show you is from like 2013, so there's even more since then on the efficacy of a lot of these treatments, the safety profile, most importantly. However, it's still considered experimental, so it is cash pay only. We do at Spine Nevada, though, offer some payment plans for these therapies if that's something you'd like to learn more about, as well as care credit we're accepting for these treatments. Okay, like I said, more and more data has been getting published with respect to PRP in this case, as well as some of the bone marrow and lipo aspirate treatments. Each year, they're coming out with more and more things, and there's active, ongoing clinical trials, of which some of the people I trained with were a part of in the US. So again, it's becoming better and better studied. As with everything, it continues to and needs to be better and better studied. But in terms of the safety profile, in terms of likelihood of giving you some good relief for your painful joints, etc. There's lots of information out there now. So just again, as an overview, these are the different types of regenerative treatments out there. Your own blood then leads to platelet-rich plasma. We'll talk about that in a sec, but I just wanted to continue to emphasize we're not doing any of the allograft, stem cell, amniotic tissue type things, which come from a donor tissue or is grounded out and then put into a liquid form to inject from a capsule or something. But we do these top 4 here. So what is platelet-rich plasma? It's a biologic means to give you some physiologic wound healing and tissue regeneration. It was primarily used when it first came on the scene to help with wound healing. A lot of the earliest studies that showed it was beneficial was in diabetic wounds chronically that wouldn't heal. And PRP was injected in and around the wound along with the assistance of the regular things that would go on with wound care, and these wounds that hadn't been healing for years suddenly were having some significant improvement. So wound healing due to the skin, but then also soft tissue. I want to think about that as well, and we'll show you something about that. So what is it in it? It's got a large concentration of platelets, which is great for healing. It's the first thing that comes in when you've injured any type of tissue, as well as white blood cells. Minimal amount of red blood cells. We do our best to eliminate as many, if not all, red blood cells if possible. It can be a little bit inflammatory. And then within the plasma itself, there's different ions, cytokines, fibrin clotting factors, dissolved proteins. So these I'm going to focus on a little bit. Specifically, these growth factors. So there's good and bad cytokines. So there are inflammatory ones that can make inflammation worse, can lead to further degrading of your cartilage and your bony structure. But there's also good ones that we collect within the PRP and then inject back in. As far as the growth factors, we'll talk about the specifics of them a little bit more, but there's what's called VEGF, vascular endothelial growth factor. This is important for bringing in increased vasculature or blood flow. If you remember nothing else, just remember that blood flow is good, and an increase in the amount of blood flow is even better, because that is what's bringing in this healing process to try and get you out of this painful or negative inflammatory arthritic process that you've been stuck in for a while. Same goes for epidermal growth factor, insulin growth factor, fibroblast growth factor. These are ones that we're going to, again, talk about a little bit more. So again, this VEGF stimulates regeneration by recruiting these bone marrow cells into the wound, or in this case, your soft tissue injury. It can increase vascularization. Again, if you remember nothing else, increasing vascularization is what we want, is good. It leads to healing over time. Insulin-like growth factor has been shown in a lab to stimulate chondrocyte cell division. Chondrocyte cells are the ones that are on your cartilage and bone growth. Epidermal growth factor just overall stimulates cell growth and healing again within that inflammatory environment. Yeah, I didn't want to get too much into the nitty-gritty, but same thing here, where we're getting rid of bad stuff, washing it out, that's creating inflammation, bringing in new things to create a healthier and more what we call anti-inflammatory environment versus pro-inflammatory that arthritis is. So this angiogenesis, again, blood flow is good, and promoting tissue granulation formation and healing, again, over time, compared to a steroid injection, which will knock down all the inflammation process, but isn't bringing in any of this other stuff to also induce increased healing. So I think of it this way. It's a busy slide and how it relates to osteoarthritis. So I apologize for the busyness here, but this is an example of what happens. So blood flow is good. So this is some vascular impairment. This is just the regular time course of osteoarthritic changes, okay? And once we get some breakdown in blood flow for whatever reason, it leads to changing oxygen levels, decreasing the health and nutrition that goes to your cartilage cells, which they need, of course. And with time, then, because those cartilage cells are breaking down because of that, what's those pro-inflammatory cytokines, not the anti-inflammatory, but the pro ones, we get cell death, we get breakdown of the cartilage, and we get osteoarthritis, which then can be painful. And unfortunately, it's just like a negative cycle that builds on itself. And once you have this pro-inflammatory environment, it just kind of continues, which is why maybe you had an x-ray 5 years ago and it showed you had mild arthritis. Your knee pain hasn't gotten much better. You got another x-ray and now it's moderate to severe arthritis. So it's because that environment has persisted. The mechanics have persisted that were poor to begin with. And we just haven't been able to get out of this pro-inflammatory phase. So this is specific for wound healing, like when you think of the dermis or the skin level. But I tend to extrapolate this out when I think of our regenerative therapies. So there is a gradual progression that occurs with cell healing and wound healing specifically, and that starts straight away after an injury with the inflammatory phase. So this is good. This is what we want. If we didn't have this, we wouldn't start to heal. But we want to move out of this inflammatory phase, which in the case of like if you cut your skin would be like the first 10 days. And then within that first 10 days, we start this next phase, which is this cell proliferation matrix deposition phase. And then at about that 10-day where the inflammation's kicked out, then the matrix remodeling or the cellular remodeling occurs, leading. So if we go down here and you think about it with respect to what we're doing with our cell therapies and with PRP, you have a chronic tendon wound. Think of it that way. And by injecting a bunch of these growth factors through the PRP, these anti-inflammatory cytokines to wash out the inflammatory environment, we are giving it like a supercharge basically of platelet activation, which then maybe you're in this chronic inflammatory phase, you couldn't get out of it over here. And because we've kind of supercharged this area with macrophages, anti-inflammatory cytokines to push out the pro-inflammatory cytokines, we then, remember VEGF and those other guys that we just talked about that are in the PRP, that are in our other cell therapies, push you into this angiogenesis, which is angiogenesis, fancy way of saying increased blood flow. And then we had the profibrin and everything else that then allows you to then start to lay down over time these remodeling factors, which lead to actual healing and improvement to your pain, ideally, with time here. So it doesn't happen right away. Whereas when you do a steroid injection, you feel better, it gets rid of this stuff straight away. But we don't necessarily push into these things over here, which is what we're really shooting for in the long run, which is why a lot of the studies that are being published now and everything show there's a superiority, maybe not at 1 month compared to a steroid injection, but 3 months, 6 months, 1 to 2 years, still having sustained relief that wasn't there before. And I think of it because of this process here that's undergoing, and we kind of supercharge it with the injecting that PRP or your cell therapy at this inflammatory level that you couldn't get out of because you're in this negative cycle. So hopefully that wasn't too much, but I felt it was important to discuss. So what about the procedure itself? So platelet-rich plasma, it's safe, it's very simple, it's literally a blood draw. So we do it in the office. specifically our South Meadows and Double Diamond office at this time. And the blood is then collected, put into a couple tubes that are then centrifuged down at a high speed. We do it 2 times to get the purest PRP we can. Again, we want to eliminate as many red blood cells as possible. They're a lot heavier than the other stuff, so they go and sit at the bottom after you've centrifuged, and then you can pull out all the good stuff out of the top. Once we've pulled it out, we can then, in turn, using X-ray, using ultrasound, put it into those problem areas that we would have determined ahead of time. So here's an example. We use the Excel PRP. We'll see in a sec, not all PRP is created equal. So this is prior to the spins. This is just whole blood. Looks like a lot. It is a lot. But after spinning everything down, we only want the good stuff. This is what we're left with. And then from here, to make it easier to inject, because it is a little bit viscous, I put it into smaller syringes using sterile technique the whole time because we don't want any infections. This is our little ultrasound gel here before one of our more recent injections I did for a gentleman's spine to make sure we don't have any infections or anything like that. It is always a risk, of course, anytime you do any type of needle through the skin, but we do our utmost to keep it as sterile as possible. So is it all the same? No, shocker. The system we use, we're pretty happy with. It's from Apex Biologics. Their platelet concentration after the centrifugation, where it's spun down, gets up to about 16 times the baseline concentrations of platelets. This is what it is fantastic. I mean, ideally it's up to 7 to 9 times. Several other systems would be about 5 to 6, which again isn't terrible. And again, you might feel better, but we want to try and offer you what's best. And so that's why we've kind of partnered with Apex here for our use of PRP after the research we had done. So moving forward from PRP then to some of the cell therapy treatments, again, the bone marrow aspirate and lipogems. We refer to them as, I've heard them pronounced mesenchymal, mesenchymal. I prefer mesenchymal stem cells. They're unspecialized, undifferentiated cells, meaning they haven't picked out what exactly they want to be moving forward, and they can divide and change into what they will be at a later stage. And they do that either through self-renewal or what's called potency. Self-renewal is where you reproduce itself over and over again, as opposed to potency, which can change into different cell types. Again, this might be a little bit more than what we need for this lecture, but we'll kind of do this 20,000 foot view here. So again, this is just a graphic depiction of either the potency, where it changes into different types here, or the self-renewal again, where it replicates itself. Okay, so where are these found at, and how do we acquire them? So the vast majority are concentrated either in the bone marrow or fat tissue. The largest concentration within the bone marrow happens to be in the iliac crest. So that's where we extract it from. There's actually a very high amount in the tibia as well, but it's just a much smaller volume of concentration. And the tibia is probably a lot, what it is, more painful than like the iliac crest. As for the fatty tissue, it's basically liposuction that we would do to extract out the fat and then break it down to just the MSCs, as well as the growth factors and pro or anti-inflammatory cytokines and things that came with the PRP as well will be found within these. So, like we talked about, taken from the iliac crest, we use X-ray, use ultrasound to help determine right where that bone is. We numb it up big time, and then after appropriate amount of time has been used for numbing, we then put down what's called a trocar to extract out that bone marrow aspirate. And this then is put, like you saw with the PRP, into a system where it's then spun down into just the stuff we want, which is usually sitting on top, whereas all the things we don't want sitting on the bottom. And once that is completed, the aspirate is put into different syringes again using sterile technique and placed back into the shoulder, the hip, the elbow, whatever it is that we might be doing that day for you. As opposed to the fat, which is, again, like liposuction, is very, very small incision after numbing use. A substantial amount is made in the flank here, and most people were able to get all we need from the fat that's located more towards the center of the abdomen here. Some people we get more so from the flank, just depends on your body type and shape. And it's placed into a collecting system. This it's not a centrifugation. It's a filtration system where it's washing out a lot of the oils from the fat that we don't need or don't want to inject back in, and you're left at the end of this filtration system as ball bearings and normal saline and all these things that we use to wash it out with this really, it's almost like pretty looking like yellow solution of just the MSCs and other, again, anti-inflammatory and growth factor type products that we want to help induce the healing into that system or into your joints and stuff. What's this? The procedure, I'm sorry, kind of got ahead of myself. So yeah, so we numb you up extensively beforehand, let it sit for several minutes even to help with any discomfort from the extraction portion of the procedure. Once we've obtained it, again, it goes back into the centrifuge unless it's the fat, in which case it's put through a different type of filtration system, and then they're carefully injected back into the site where we were focusing on. So in summary, what are some of the things that we're treating here at Spine Nevada, which I know is part of the challenge of doing this at Spine Nevada, one that we welcome and that we're trying to kind of get out there more, is that we are more than just Spine Nevada. That is absolutely a major component that we do in terms of treatment, but we want to also, again, try to address that orthopedic treatment gap that we talked about at the beginning of the lecture more and more. And we're starting to partner with our friends over at Tahoe Fracture and things like that too. So we're hoping to get the knowledge out better that there's more to Spine Nevada than just treatment of spine. So these would be basically any joints: your shoulder pain, elbow, wrist and hand, hips and knees, foot and ankle, neck and back, of course, and then osteoarthritis as it's related to all these issues. Yeah. So after you have an injection, then what? So like I said, it's not going to be as instantaneous as the steroid injection perhaps that you've had before. Ideally, you'll start to see improvement within that first month to 6 weeks. The other thing with the injection itself, it can actually, just full disclosure, can be a little bit more uncomfortable and painful the day of, because we are trying to wash out, put in a decent volume of this anti-inflammatory and pro-healing substance that isn't just a bunch of numbing medicine that's going to make you feel better right then and there, but it's the long-term improvement that we're really shooting for. So again, usually that month to 6 weeks, you see an improvement for what it is that we were treating, and then it's been shown to be sustained much better. Usually 6 months to a year is where you'll continue to see improvement, and then at that point, that's probably about where you're at. Can you get tune-ups? Can you get re-injected? Yes, absolutely, safely with these things. Unfortunately, again, like we talked about, it's not covered by insurance, but if it's something that you're very happy with and satisfied with, you think about your deductible, you think about, how much you're putting into that each year. If we're treating it this way, it actually might end up being cost savings. Thank you for your time and attention this evening. Chronic pain is no fun. It's difficult to treat. We're always trying to come up or use different means of treating it, and hopefully if this is something that you're interested in, this would be something that would be successful for you. And by we, I mean myself. I'm Dr. McDermott, but I also have a couple other fantastic colleagues who I really enjoy working with, Dr. Andrew Sue and Dr. Michael Rozak, who just joined us as well from Emory. And all three of us are very interested in this world and are using these orthobiologics to, again, help our patients feel better and get back to doing the things they love to do, hopefully sooner than later. I guess we'll go to the Q&A now, and happy to take all your questions at this time.